Uh, Very good morning, everyone. Welcome once again to ISG Masterclass. This is the 17th in the series of Masterclass. Uh, you all heard a talk by Dr. A.C. Anandi last week on a important topic such as sarcopenia and chronic liver disease. We got a lot of appreciation mails from lot many participants, and most of the participants liked his speech and his lecture, and people liked more about the way he defined the gaps in knowledge. That's what really wonderful. Thank you, Dr. Anand, for telling us the recent advances in sarcopenia and chronic liver disease, and also letting us know the gaps in knowledge about that. Again, next in the series today, we have one other important topic, that is how do you treat chronic hepatitis C? And all of us agree that there have been a sea change in the treatment of chronic hepatitis C over the last, say, 7 to 8 years. And now Hep C is mostly curable disease. There are many questions. How do you treat a common chronic hepatitis C? And how do you treat a chronic Hep C in special situations? And to address all of these, we have very eminent speaker today, Dr. Pankaj Puri. He is very well known to all of us. He is a remarkable speaker, a great teacher, and he's one of the person who had helped INASL to make guidelines on chronic hepatitis C for India. He had been the lead author in that work. Dr. Pankaj Puri, as we know that he was with Army Medical Course. He was the head of Department of Gastroenterology at Armed Forces Medical Sciences at Pune, and then now he's working as head of Department of Gastroenterology at Fortis Scots Hospital in New Delhi. Dr. Puri is a very good friend of ours, and he's a great association with Dr. Puri for last almost more than 2 decades. Welcome, Dr. Puri, and we look forward to listen to you on chronic hepatitis C. And it's such an important topic for all of us. And to moderate the session, again, one of the legends of gastroenterology in our country, Dr. Setu Babu, very well known, very pleasant person, always smiling and always very enthusiastic in taking any role you give to him. He is head of gastroenterology at KIMS Hospital in Hyderabad. And we welcome Dr. Setu Babu for moderating this session. Welcome, Dr. Saraswat, and I hand over the proceedings to you to take it forward from here now.
Thank you, Dr. Govind. Good morning, ladies and gentlemen. I welcome all the participants for today morning's webinar on chronic hepatitis C. As Dr. Govind had presented in the last series of lectures, on an average, we are fortunate to have the participation of about 1,000 to 1,100 participants every day in every one of these sessions, and also people participating from about 28 countries around the world. In fact, Bangladesh, Nepal, Kenya, Myanmar, we have had a very large number of participants from these countries, and I welcome all of you to today morning's session. As the other point I'd like to make, and I think many of you are aware and are using the archives that have been made of all these presentations at the ISG website. On the library tab, you find all these presentations filed away with the questions that are asked and the answers that the speakers provide for reference in the future as well. As Dr. Govind has said, we will now be listening to Dr. Pankaj Puri on chronic hepatitis C. As you all know, 2014 marked a turning point in the management of chronic hepatitis C, after which, with the availability of directly acting antivirals, including sofosbuvir, hepatitis C, from being a scourge in the world, has now become a curable disease, and many countries have launched elimination programs for hepatitis C. And in fact, India also has a national hepatitis control program ongoing, under which investigations and treatment for hepatitis C are provided by the National Health Services. So, as mentioned, to take us through this journey of how hepatitis C from being a dreaded disease has now become a controllable and a curable, maybe one of the first diseases that might be controlled only by treatment rather than by vaccination. We have none other than Brigadier Pankaj Puri. And as Govind has told you, he was the leading spirit behind the INAZL consensus on chronic hepatitis C, as well as the clinical practice guidelines, two versions of which came out before the National Hepatitis Control Program guidelines emerged in 2018. Pankaj has been a very astute, sharp clinician, as well as very precise and to the point and up to date in his presentations. Now, also welcome Dr. Setu Babu to this session. Yes, Setu has always been a very enthusiastic and a very sharp observer and interlocutor in these gastroenterology, hepatology sessions around the country. With these few words, I will now request Brigadier Puri to please begin his presentation.
Thank you, sir. Thank you so much for your kind words. And it's a pleasure to come and be part of this wonderful program. I hope my slides are visible to everybody.
Yes, they are. That come on nicely.
Thank you, sir. So India accounts for a large burden of diseases of bulk of the worldwide HCV burden. We have a population of 130 billion. And if you look at a prevalence of 1%, that would make it minimum of 13 million HCV infected individuals in India. But the biggest issue is that only less than 5% have been diagnosed and less than 0.2% of people have received treatment. And this for a disease which we can really cure purely by treatment is sad. I don't know why it's not working. Okay, sorry. So let me take you down memory lane. These were the 2002 INAZL guidelines of the management of hepatitis C, and they said treat with interferon and ribavirin. And we've come a long way from there. We used to have many predictors of response, and we used to look at rapid virological response, early virological response. We used to worry about IL-28B polymorphisms, and all that now is history. The treatment has gone and evolved from what was bad, which was the interferon-based therapy, to what became a little ugly, which was the tenofovir, boceprevir, and now the good ones, which is the DA. The interferon-based therapy had many issues which went with it. First of all, the efficacy was poor. There was a great risk of decompensation. And people who had even child-age cirrhosis, we would give it with a lot of caution. There would be cytopenias, fever, thyroid dysfunction, and many other things. Then came the tenofovir and the boceprevir. For peculiar circumstances, they didn't even touch the Indian shores, and they went. And before we could even think of getting them, we finally had good new therapies which came in. These were the directly acting antiviral agents. It started with the story of sofosbuvir in 2013. Sofosbuvir was invented by Michael Sophia in 2007. And as soon as the drug was about to go for FDA trials, was picked up by Gilead. The initial company was PharmaAssist, which was bought over by Gilead. And within a year, they had done about $10 billion worth of sales. And we can see that the response rates have steadily been increasing from standard interferon to directly acting agents. And really the newer DA agents have taken the treatment response up through the roof. Every 6 months, the guidelines of hepatitis C have changed and evolved over the last few years because of newer and newer drugs getting regulatory approvals. This was what came with Gilead starting and marketing the drug in India. What was sold as $1,000 a pill was sold in India subsequently at 1/100th of the cost. And that is what changed the availability of the drugs and availability of treatment for hepatitis C in India. So the framework of the talk, which will be the life cycle of hepatitis C and what are the therapeutic targets which form the basis of therapy, the directly acting antivirals, the diagnosis, evaluation, and assessment of hepatitis C, the treatment recommendations of standard cases. Now, standard case is a patient who either has no cirrhosis or compensated cirrhosis. What is the currently available guidelines? But many of the drugs which are recommended are not available in India. So what should we do in India? And finally, the treatment in special situations, which is decompensated cirrhosis, transplant, kidney disease, HIV, and many other such co-infections and other things. If you look at the hepatitis C RNA, it has a 5' region and a 3' region, and it gets translated into polyproteins, which have both structural as well as non-structural regions. The NS3 region is the protease, and drugs which act on these protease inhibitors are the protease inhibitors, which include all the previrs. The NS5A forms the replication complex, and all the drugs which act on NSA5A inhibitors are the daclatasvir, ledipasvir, velpatasvir. And the third group of major group of drugs is what acts on NS5B, which is the polymerase, and the initial index drug sofosbuvir belongs to this group. If we look at the life cycle of hepatitis C, the hepatitis C undergoes receptor binding and endocytosis, fusion and uncoating. It's translated into polyproteins. There is RNA replication, virion assembly, and release. So all the drugs act at various parts of this life cycle. The protease inhibitors act on the translation and polyprotein processing. The polymerase, NS5B polymerase inhibitors, which includes sofosbuvir, acts on RNA replication. And the NS5A inhibitors act on the replication complex and the assembly inhibitors. There are tons of names, and how do we really remember these names? I think the nomenclature name itself tells you which group the drug belongs to. The NS5B inhibitors, the B starts with buvirs. The NS5A, so A stands with asvirs, and the protease which starts with PR are the previrs. So if you see anything, a glecaprevir has a PR inside it, so it's a protease inhibitor. And a ledipasvir has an AS inside it, so it's a NS5A inhibitor. The genotype, the currently available drugs are used in combinations and not as single drugs. They are available as pan-genotype combinations and genotype-specific combinations. Sofosbuvir is used along with daclatasvir, velpatasvir, and these most of them are available as combination therapies, except as sofosbuvir and dacla, which are also available as individual drugs. So all the other drugs are available as combination therapies. There are 4 pangenotypic combinations, which is sofosbuvir dacla, sofosbuvir velpa, glecaprevir pibrentasvir, and the 4th one, which is used as a salvage therapy, is sof-valpa along with voxilaprevir as a combination drug. This is marketed by Gilead as Vosevi, and the glecaprevir pibrentasvir is available and marketed as Maviret by AbbVie. But if you see, only the first 2 are available with us in India, and that sort of limits a few of our options. Similarly, the genotype specific combinations are sof-velpa, sof and ledipasvir for genome 1, 4, 5, and 6, and elbasvir, which is grazoprevir. But again, out of these, we have only the first one, which is available with us in India. So only one genotype specific combination. So among the available HCV combinations, only the ones in red, that is sof-velpatasvir, as 400 and 100 milligrams, and sof-daclatasvir as 460 milligram, is the pan-genotypic combinations available with us. And the genotype-specific combinations, sofosbuvir and ledipasvir 90 milligrams, is the available combination in India. So although glecaprevir pibrentasvir is not available in India, it's really the toast of the guidelines, and we must touch a little bit about it. It's a combination of drugs which act on NS3 and NS5A. This is a sea change from the available drugs in India, because the available drugs in India all dependent on action on NS5B, which is the RNA-dependent RNA polymerase. So here's a group of drugs which are not including sofosbuvir, which includes a NS5A and a protease inhibitor. There are many trials which have been carried out on this drug combination, which includes the previously treatment experienced patients, patients with kidney disease, patients who have HIV, and patients who have transplants. So in all of them, if you see across the board, the results are outstanding. So if we look at patients, the response of the therapy for 8 weeks in patients without cirrhosis, these were the trials which included the Endurance 1, the Surveyor 2, and the Endurance 3. Endurance 3 trial was for genotype 3, and these trials were, Endurance 1 was for genotype 1. In most of them, again, we see a fantastic response, except in a small subgroup of patients with genotype 3. Now, we need to touch on this a little later, and which with A30K RAS mutations. These two trials were published in 2018 in NEJM as a combined paper, which was the Endurance 1 and Endurance 3 trials. The Endurance 1 trial randomized patients into 8 and 12 weeks and on Geno 1. And in Geno 3 patients, we had 3 arms, 12 weeks of glecaprevir, pebrentasvir, soft dacla for 12 weeks, and the third arm of 8 weeks of glecaprevir, pebrentasvir. If you look at this response in Geno 1 and Geno 3, again, across the board, outstanding results of the drug. The other major drug which has been combination which has been recommended by all guidelines is the combination of SOF and valpatasvir. If you look at non-Geno 3 combinations, it was the Astral 1. And in Geno 3, again, Astral 3. Across the board, again, outstanding results of almost 97 to 100% in all these trials. So how do we diagnose, evaluate, and assess hepatitis C? I think the most important part is to screen and identify early and treat to prevent HCC and development of end-stage liver disease. The hidden iceberg is what matters in these elimination goals, because we see a little bit here, but what we don't see is the large amount of hepatitis C burden below the surface of the water. So we must screen people with high risk exposure, high risk behavior, or in people who have co-infections with hepatitis B and HIV, or have persistently abnormal AST and ALT. The high risk behavior would be IV drug use or risky sexual behavior. High risk exposure would be hemodialysis if the mother is positive, healthcare workers with needle stick exposure, and these are people who would be high risk exposure. So how do we evaluate a patient with hepatitis C infection? If you have a patient who comes to us with anti-HCV positive, how do we do? The first thing is to make sure that the patient is replicating. Just anti-HCV is not enough. We must check and see that the RNA is raised. In some people, the anti-HCV may be negative, and the diagnosis of hepatitis C infection may be made by HCV RNA. That would be patients who have acute hepatitis C and people who are immunosuppressed. An option is hepatitis C core antigen. It's cheaper, it's easily available, but it has a slightly lower sensitivity and still needs to come in community programs. We need to look at the severity of liver disease, rule out cirrhosis, fibrosis assessment, rule out comorbidities like renal dysfunction, hepatitis B, C. We must do a pregnancy test in women of childbearing age, and do a virological assessment besides RNA, which includes genotype, and we will discuss the role of genotype and the role of resistance associated substitutions. Fibrosis assessment is important. We need to see and look out for cirrhosis. It may change the regimen, the duration, and the combination used with ribavirin. Also, if cirrhosis is present, we must look for decompensation. We also need to look and follow up these patients for development of hepatocellular carcinoma and varices on post-SVR follow-up. Biopsy is rarely required. We do transient elastography or we do serum tests like APRI or FIB4, which are very simple and good negative predictive value. What about ultrasound? We do it routinely and most importantly, simple way to picking up cirrhosis. But remember, in early cirrhosis, it may miss cirrhosis. And also, the other importance of ultrasound is to look for hepatocellular carcinoma. So simple ways of fibrosis assessment is to do a APRI, which is you do a simple calculation of the AST levels divided by the upper level of the normal level of the AST, divided by the platelet count into 100. And if the APRI is more than 2, the patient has cirrhosis. The APRI is less than 0.5, there's no significant fibrosis. The other simple test is FIB4, which is again a simple calculation of which includes AST, ALT, platelets, and age. And a level of less than 1.45, there's no significant fibrosis. And the level of more than 3.25, there's likely fibrosis. The other things we can look for, which will guide us, if the platelet counts are low, patient has a splenomegaly, we should start looking for cirrhosis. What about resistance-associated substitutions? They're expensive, not routinely available. And when should we do it? The recommendations are in elbasvir, grazoprevir, and Geno 1A, but it doesn't affect us because we don't have the drug. Second is soft ledipasvir who Geno 1A who are treatment experienced. And if you find these RAS mutations are low, we give an alternative regimen. But here's another one where they're strongly recommended by the guidelines which are there. The ASLD guidelines are recommending. If you have, for example, use soft Velpa and Geno 3 who are cirrhosis over treatment experience, you look for mutations. And if you have the Y93H mutation, you add ribavirin or give an alternative box containing regimen. In India, we are not routinely recommending. One, it's not available. And secondly, if your alternative regimen is to add, which is not available, then why are we checking for it? So there are a lot of treatment options. How do you choose the right treatment option? The good news is that all of them work very well. And the SVR rates are more than 95% in clinical trials as well as real life studies. They're tolerable, safe, and for most patients, any of the recommended options are going to be fine. But we have to be careful on specific situations like cirrhosis, transplant patients, kidney disease, HIV co-infection, other drugs, etc. When we start and choose a regimen, we must have a checklist. We first and commonly do genotype, and we'll discuss whether it's still necessary. Sometimes we need to do a resistance. More than the first two is we look at treatment history. And see the variations, recommendations will change as per previous treatment, whether they received interferon, whether they received DA, and if they received DA, did they receive just soft or did they receive velpatasvir or daclidasvir in the past? Comorbidities like renal functions, hepatitis B, C, if they have other diseases like cancer where life expectancy is less than 1 year, then we must wonder why we are treating. We must check for drug interactions, stage of fibrosis, exclude cirrhosis, and exclude pregnancy or childbearing potential. We must remember that ribavirin is teratogenic and the safety of the other drugs also is yet not conclusively proven. Access, cost of therapy also needs to be remembered. Whenever the patient is started on a drug, we must check the interactions with other drugs. And this is a simple app, a simple website and an app which is available. This is the website and this is the app which is available. This is available from Liverpool. And you must not trust your memory. You must look up all drug interactions, including over-the-counter drugs. What about recommendations which are recommended by standard guidelines? If you look at this one sort of page, summarizes 100 pages of the guidelines by ASLD. The ASLD guidelines recommend that in Geno 1 or 4, you have 4 options. The first two options are not available in India, which is elbasvir, grazoprevir, and glecaprevir, pibrentasvir. What interests is these two, which are available in India. The combination of SOF with either ledipasvir or velpatasvir. Both of them are recommended for 12 weeks. There is data to suggest the ledipasvir treatment duration could be decreased to 8 weeks in people who have no cirrhosis and people who have low levels of HCV RNA. For Geno 2 and 3, the available regimen for us is SOF and Velpa for 2 weeks as per the ASLD recommendations. For Geno 5, 6, again, the combinations of these are rare genotypes, and the combination of ledipasvir, velpatasvir is what would be available for us. But if we look at these guidelines, none of them talk of declatasvir, which is still being used very widely in India. So the pan-genotypic combinations which act across all genotypes are SOF-Velpa, which is available with us, and glecaprevir, pibrentasvir, which is available with us. Along with this would be Dacla, which would be sort of pan-genotypic as well. The genotypic specific ones, ledipasvir and SOF, across the board for 1, 4, 5, and 6, except for Geno 2 and 3, can be used. These were the EASL guidelines, which also included other drugs like the PROD regimen, but these guidelines were made in 2018, and I shall not touch on these further, except to say that again in these guidelines, declatasvir has not been recommended so far. So genotypes, do they matter anymore? Historically, genotypes have been very important in predicting response to treatment, more so in patients who were on interferon therapy. More recently, they have allowed us to choose the appropriate DA regimen. And the current role of genotypes is in selecting cost-effective therapies, predicting prognosis, determining relapse versus reinfection. And supposing a patient is got cirrhosis, there, how do you choose with the specific therapy? The ASLD has also gone ahead and said that we really don't need to check genotype in every patient. Who's eligible for simplified therapy without genotype testing are people who don't have cirrhosis, who don't have kidney disease, don't have other comorbidities. If they have standard, no significant fibrosis, no HCC, no prior liver transplantation, these people can be given simplified regimen of therapy. So in these patients, you don't need to check genotypes, and you can just simply calculate their fibrosis, rule out cirrhosis, do basic tests, including checking for hepatitis B, HIV, do their RNA, rule out pregnancy, and treat them. What treatment do you give them? Only two options. Either glecaprevir, pibrentasvir, not available in India. This is a combination of 3 tablets once daily for 8 weeks, or the second option of SOF-Velpa for 12 weeks. This is 1 pill a day. Now, no monitoring is recommended, no LFT. The only thing you need to look for in this therapy is to rule out hypoglycemia if patients are diabetic on drugs, or look for INR if they are on anticoagulation. The national guidelines are slightly different. Now, these are national guidelines which came in 2018. Remember, they were in 2018, and second, they are made with a public health perspective and are hence appropriate. They say if a patient has HCV RNA positive, you do basic tests to rule out presence of cirrhosis. If the patient does not have cirrhosis, you treat them with SOF and declatasvir. If the patient has compensated cirrhosis, you treat them with SOF and velpatasvir for 12 weeks, and you just check for sustained virological response 12 weeks thereafter. So no checking of genotypes really. So patients with uncomplicated cirrhosis would receive SOF-Dacla. Patients who have compensated cirrhosis would receive SOF and velpatasvir. Decompensated patients would have ribavirin. A few things have changed since 2018. One, we can't really write off the other regimen in people who have no cirrhosis. Second, there may be some role of adding ribavirin in these patients who have compensated cirrhosis as well. And I will touch on these couple of points as to what should be the practical points of management in 2020. So the issue one is that soft DACLA is an effective pangenotypic regimen and a lot cheaper. And this is not something which has been incorporated in the guidelines other than the Indian guidelines. Look at these endurance 3 trial of comparing glecaprevir pibrentasvir with soft DACLA. These were 12 weeks of each therapy. The response rate with glecaprevir or maviret is 95%. That with DACLA is 97%. This is designed as a non-inferiority trial for glecaprevir, but definitely at no stage does it show that DACLA is inferior in any way either. If at all, numerically the numbers are more. Here's another trial which was done, which is there on clinicaltrials.gov, which has been presented in the EASL. Full paper hasn't come, but again in GENO-1, if you look at the combination of soft ledipasvir and soft DACLA, the results of soft DACLA are almost 97% sustained virological response. Overall in GENO-3, the response has been slightly lower, but across the board, the response is not too bad. And these were all generic drugs. This is real world data of soft and daclatasvir compared to soft and velpatasvir in GENO-2 and 3, which was published in Journal of Hepatology in 2019. This was 5,400 patients receiving soft DACLA or soft velpa with or without ribavirin. You find, if you look at this data, the chance of achieving cure was the same whether patient received daclazofir plus soft or velpatasvir plus soft when you compared in regimen which had ribavirin or regimen which did not have ribavirin. Another real world data from Thailand, the results of soft DACLA are 98%, which are even more than, numerically more than velpa. This is data from SGPGI, Dr. Rakesh and Amit Goel, and they also have shown that patients who had soft daclatasvir, no cirrhosis 96%, and compensated cirrhosis 93%. Of course, in decompensated, the results go down. But overall response rates in compensated patients is very good. The second issue is ribavirin required in compensated cirrhotics? This was a study in 2018 by Esteban, and it compared ribavirin in compensated cirrhotics, genotype 3 patients. If you look at patients with ribavirin, numerically at least, they had higher response rates in patients on ribavirin. But in patients who had Y93H substitution, this is the place where the role of ribavirin was most important. And hence the ASLD guidelines, these are the ASLD guidelines, they recommend that all patients with genotype 3 and compensated cirrhosis, we should check for the Y93H mutation, even when we are giving velpatasvir. So ASLD says check for baseline Y93 substitution, genotype 3 compensated cirrhosis, and if it is present, you add ribavirin to the regimen or give some other regimen. Problem is we don't have any other regimen, and our only option is to give ribavirin or test. Since testing is not practical on large scale, it makes more sense to consider adding ribavirin in these patients. And hence, I have in this table outlined the treatment options of patients who are in GENO-1 and GENO-2-3. Patients who have no cirrhosis can have soft with velpatasvir, ledipasvir, or DACLA. All three options would be good options. And ledipasvir would not be recommended in patients with GENO-2-3. Patients with compensated cirrhosis, probably the best regimen is velpatasvir. And in GENO-3 specifically, we would add ribavirin in these patients. The DACLA results overall have been inferior, more so with the data which has come from decompensated patients. So in patients with compensated cirrhosis, these would be considered as alternative regimen. I think with that, the next part of my talk will be treatment on specific situations, which would be decompensated cirrhosis, transplant, treatment failures, HIV, HPV, chronic kidney disease, etc. And we can take a break here, which was planned, and I would leave the choice to moderators.
Yeah, I think it was a very crisp and beautiful talk and covered a majority of the situations. I saw some of the questions, most of them are addressed on hemodialysis and thalassemics, which you are and children, which anyway you're going to address. There was one interesting topic which somebody is anti-HCV positive and HCV RNA negative. Do you treat them? This is an issue which sometimes you face.
If patient is anti-HCV positive and HCV RNA negative, he does not require any therapy. And I think
the second point is in your talk, could you stress on the duration of therapy? There has been, regimens which said even 1 week therapy, ultra therapy, which were discussed in the articles. But we talk about 12 weeks versus 24 weeks. Could you just highlight where do you do 12 weeks and where do you do 24 weeks?
in all cases, the regimen recommended is 12 weeks, except when we want to use ribavirin, that is one patients. In patients where we plan ribavirin and they're ribavirin intolerant, that is the place where you would consider 24th weeks of therapy. The second thing which you see in this table, where I have stuck my neck out a little and said that if you're using in compensated cirrhosis, you are using DACLA as a choice, that is one place where you would consider using 24 weeks because the response rates have been lower.
Are you also going to make a comment on once you achieved, complete viral response, and how would you like to monitor them as a stress? Because the concern that they might get HCC is still there, particularly if there's a significant fibrosis or cirrhosis.
Oh, true. I had planned to discuss that in the next part of the talk on decompensated cirrhosis, but I can cover it here. I think just achieving SVR is not enough in patients who are cirrhotic. They need continued monitoring, and that's very important. And monitoring basically focuses on two things. First is development of hepatocellular carcinoma, and the second thing to monitor on is the presence of varices and prevention of variceal bleed. These are the two most important things.
I think there is, an impression that GT3 is very common in India and tends to be resistant. Would you like to recommend Sofawel first or Sofadacla first in case you find them as GT3?
In GT3, you are right. GT3, what is with DAs, the fear we have with GT3 is the same fear we had with Geno1 in patients on interferon, that the response rates should be poorer. But the poorer response rates in GT3 are in patients with cirrhosis. In patients who are compensated, who are non-cirrhotic, the response rates of DACLA are also as good. And we should not write off DACLA in people who are non-cirrhotic. DACLA in our national program has been recommended as the first-line therapy on a public health program. And truly, since it's much cheaper, it's 1/3 the cost, or half or 1/3 the cost of Velpatasvir, we should not write it off. Its efficacy is also very good. As I showed data of value of DACLA, and if you look at these comparative data look at the response rates. This is genotype 3 response rates of soft DACLA, 97% response rates. That's very good. Even our Indian data, if you look at our Indian data also, this is response from Thailand, 98%. Response from, this is SGPGI, 96%. They have very good response rates. I don't think there's much to choose between this and soft Valpa in people who are non-cirrhotic.
Do you end the era of interferons now anymore? I mean, or you find there will be some areas where you might take up interferon?
Sir, currently no interferon. The amount of interferon we have used with wide availability of interferon in the forces, I think we cannot justify its use anymore. There is so many good drugs with outstanding results that the era of interferon is finally over.
Can we go to talk again?
Yes, yeah. Can you continue your talk, Pankaj?
Yes. So the second part of the talk is DA in specific special situations. The first case I'll take is a patient with decompensated cirrhosis. Now let's take a sample case of a 63-year-old lady who has ascites and her MELD is 20. Her endoscopy shows varices. The ultrasound shows cirrhosis, no hepatocellular carcinoma. It's got a high HCV RNA, and the HCV genotype is 3. The questions which we as clinicians need to ask, which DA should we use? And what would be the SVR? What would be the drug tolerability and safety? Should we first transplant her or should we first treat her? That's the first question which is to be addressed. And will DA help in improving her functions and help her in getting delisted? And who should be treated before liver transplant? So there are many pros and cons of treating people who have been listed for transplantation who have decompensated cirrhosis. The pros are that the liver functions may improve, they get withdrawn from the liver transplant list, we'll prevent recurrence post-transplant, improve quality of life, and if transplant is not available, then that really, the story is over. You have to consider treatment, otherwise there's no other option. The cons are that there's a potential side effects and deterioration. The SVR rates are lower, and if they don't respond, you may have exposure to NS5A, which may compromise the response post-SVR after transplantation. You may improve them slightly. The MELD will improve. They won't fully become all right, but they'll be low priority for liver disease, a low priority for transplant, and risk of progressive liver disease. If when people were treated with DAs, this was a study across many trials, and they found lots of them improved. But if you see the worsening, 17, 16, they were worsening as well in these studies. So everybody does not improve after therapy. This was the trial by Belly of 103 patients treated with DA combinations. They looked at how many people were placed on hold on the transplant list, which means they were inactivated, and how many were delisted. And with period of time at 60 weeks, 1/3 of them were inactivated and delisted about 20%. 1 in 5 patients were delisted. But the people who improved were the ones with lower MELD. They had a higher chance of delisting and getting off the transplant list. So what's the point of no return? And when do we say this patient's unlikely to respond? So this was a study which looked at SOF and declarasphere in decompensated cirrhosis. All of them had a MELD score of more than 15. And they found that the cutoff was about 20. So the improvements were limited to patients with MELD score of less than 20. The important points in decompensated cirrhosis is treat with caution. They may actually worsen. Need a close follow-up. Drug toxicity needs to be kind of kept in mind. So no protease inhibitors. So the poster boy of therapy in standard cases, glecaprevir, should not be used, nor should the WOX-containing regimen. Also, some of the other DAs like ledipasvir, velpatasvir can cause liver injury. Ribavirin may have issues with anemia, although it should be considered and added as far as possible. We need to keep a MELD purgatory in mind, and I'll touch on this a little later, that if this MELD is more than 18 or 20, your risk is more likely to outweigh the benefits, and we may consider waiting in these patients. Now, this is a purgatory, it's a place of suffering inhabited by souls of sinners who have to make amends before they go to heaven. So you give them DA, they have a slight improvement, they don't go to heaven. They go into a purgatory. They're not sick enough for transplant. They lose their priority for liver transplantation. They have a poor quality of life, and they have complications of portal hypertension and risk of developing hepatocellular carcinoma. The response rate to DA in decompensated cirrhosis are lower. This was the ALI-1 study of SOF, daclatasvir, and ribavirin in advanced cirrhosis and post-liver transplantation patients. And these are the results of the cohort of advanced cirrhosis. If you see the response rates in patients with child C, they're only 56%. So very poor advanced cirrhosis, poorer response rates. Again, in genotype 3, this was the ALI-3 study, you see that overall response rates in patients without cirrhosis were 96%, has dropped down to 63% in patients who have cirrhosis. So again, in decompensated cirrhosis, awaiting liver transplantation, you find that while most incompensated patients, we had response rates of 97%, here across the board, whether it was 12 or 24 weeks of therapy, the response rates are not as dramatic. The SOLAR-1 and SOLAR-2 were two trials carried out in US and Europe. The real world data UK early access program showed that the response was markedly affected by genotype. Genotype 1 in cirrhotics, the response was down to 90%, and genotype 3 fell below 70%. And there was some suggestion that ribavirin would be beneficial in genotype 3. This was Astral 4 of velpatasvir, which had treatment naive and experienced patients of genotype 1 to 6, which had compared velpa and velpa versus ribavirin or just soft velpatasvir. And we find that in patients, if you look at compared the data, especially in genotype 3, this blue bar stands out. This is the addition of ribavirin to soft and velpatasvir in patients who have decompensated cirrhosis. So the value of genotype 3 in particular appears to benefit from addition of ribavirin. This was the European Liver and Intestinal Transplant Association guidelines consensus statement on the use of DA in transplant candidates and recipients. Pre-transplant therapy can be given with the aim of getting them RNA negative at least a month before transplant. 20% will improve and can be delisted. If the MELD is less than 16, 1/3 may be delisted. If the MELD is more than 25, you don't recommend the treatment. Again, you go beyond 20, very small minority may show improvement. In patients listed for HCC, DA therapy, if they have a low risk of HCC recurrence, you can wait, you don't mind waiting, and they are on, there's no progression of HCC while they're on bridging therapy. Similarly, the guidelines from the International Liver Transplant Society also say that the MELD is less than 20, you can give them treatment. If the MELD is more than 30, don't treat them, transplant them first. The principles of therapy besides the MELD score is you add ribavirin, don't give protease inhibitors, and if they can't tolerate ribavirin, you increase the duration of therapy to 24 weeks. You increase the duration also if you have treatment experience and possibly if you're using daclatasvir as a primary regimen. If the MELD is more than 20, transplant them first and then treat them unless you have to wait, the waiting time is too long. You look at this chart and it's sort of summarizing patients where liver transplant is an option. If it's not an option, you treat. If transplant is an option, if the MELD is less than 16, the delisting chances are about 49%. If the MELD goes beyond 20%, then the delisting chances are much lower. These were the ASLD guidelines in decompensated cirrhosis, SOF and velpatasvir, SOF with ledipasvir or velpatasvir in all genotypes except that ledipasvir is not used in genotype 2 and 3. They in ribavirin, if they're ribavirin ineligible, treat them for 24 weeks. Otherwise, add ribavirin and treat them for 12 weeks. In previous treatment failures, you add ribavirin And along with that, increased the treatment duration for 24 weeks. So ribavirin is started at a dose of 600 milligram and increased as tolerated to weight-based. The debate of HCC has been there, but this year, liver transplantation 2020, this paper has come in, and it does, the treatment of DA does not seem to be associated with increased HCC recurrence. So we have to monitor them for HCC surveillance, for varices, and decision for liver transplantation. They may still need to be transplanted. Second patient is post-liver transplantation. The patient is an immunosuppression, day 15, post-transplantation, liver functions are normal, renal functions are normal. When should we treat them? What should be the drug interaction? And what should be the choice of drugs? Post-transplant HCV gets accelerated. The optimal timing is 3 months after liver transplantation, roughly, where the post-op issues have resolved, the renal functions are normal, immunosuppression is stable, there is no ongoing rejection. Treatment, protease inhibitors should be avoided. The interaction with everolimus needs to be considered. The regimen SOF and DACLA and SOF-VELPA can be given in most cases, but again, we need to check for drug interactions. The ASLD recommendations are to use glecaprevir, pibrentasvir, or SOF along with VELPA and ledipasvir. We add low-dose ribavirin in these patients. Okay. What about treatment failures? Now, if you look at the options for treatment failures, lots of these options are not really available for us in India. These are the ASLD guidelines. They all recommend, in most of the NS5A, they're recommending give VOX. So what do? We don't have this regimen available of combination of SOF, velpatasvir, and voxiprevir. The principles of management would be that if they have PEG interferon failures, we give them standard treatment as per genotype. If they're SOF failures, we treat them with SOF, ledipasvir, or velpatasvir. If they have NS5A failures, we should defer treatment if there's no urgency. We should do resistance testing if it's feasible and treat accordingly. You add weight-based ribavirin, and treatment for 24 weeks is recommended. We don't have new drugs. We don't routinely can do resistance testing. So if we have to give treatment in people who've received NS5A, we add SOF, velpatasvir, and ribavirin, give it for 24 weeks, especially don't wait for newer drugs to come in. In patients who have HIV co-infection, we must remember that the anti-HCV can be falsely negative and the diagnosis may be by RNA. The drugs with minimal interactions are the integrase stand transfer inhibitors, that is raltegravir and dolutegravir. NNRTI, rilpivirine, is also with minimal interactions. The most important part is to recognize drug interactions. SOF-VELPA can be used with most drugs except efavirenz, itiravins, and nevirapine. The most important part of therapy is tenofovir is a part of heart regimen, and the dose may tend to be increased in patients who are on NS5A inhibitors. So we must monitor renal parameters and consider using alafenamide, tenofovir alafenamide, where a lower dose is used. So regimen not recommended. These are not recommended by ASLD have been shown, again, which have been sort of summarized in the previous trial. We have to look at the drug interactions. This chart sort of gives drug interactions, which are the green is safe, the yellow is dose change or monitor closely, and the red is avoid, or ND stands for no data. So for every drug which we use, we need to cross-check the drug interactions. What about hepatitis B co-infection? The EASL guidelines and the ASLD guidelines are shown in this chart. People who have hepatitis B co-infection, you can have a flare of hepatitis B. So the EASL guidelines recommend that you start entecavir or tenofovir prophylaxis until 12 weeks after stopping DAA therapy. That has not been recommended by ASLD guidelines. Now that's a difficult thing to practice in routine in people who are not cirrhotic. There's no urgency. So here's an interesting paper which came out in 2017, and it gave a nice flow chart. That if the patient has cirrhosis, you start nucleoside analogs together or before DA therapy, because reactivation can be life-threatening. If patient has no cirrhosis, then you monitor them closely for reactivation. If the patient has cirrhosis, treat. And again, if the patient has HbA1c negative and only IgM anti-HBC positive, even these patients can reactivate and you need to monitor them. Patients with kidney disease we've always worried about kidney disease because these patients would not tolerate sofosbuvir, and there was data to show that sofosbuvir metabolites were excreted from the kidney and they would cause toxicity. But we are getting a lot of data of sof and valpartasvir safety in patients with end-stage liver disease undergoing dialysis. And this patient paper came in 2019 in Journal of Hepatology, and they had a cure rate of 95% with no significant side effects. This is the paper which came from SGPGI with half dose satin of sofosbuvir along with DACLA and showing very good results without significant adverse effects. A meta-analysis has been carried out of 221 studies which show that SOF in patients with CKD is safe. And the ASLD is recommending no dose adjustment and you can safely give this drug. And in 2019, FDA has approved the use of SOF containing regimen in patients with kidney disease. The nephrology guidelines are also now recommending similarly that it can be used safely without any modification in these patients. Patients planning pregnancy, the risk to the baby is about 3 to 5%. You must remember that heterogeneity of ribavirin. Treatment during pregnancy, there are some trials, but cannot be recommended at present. Delivery, we should avoid invasive procedures like fetal scalp monitor, forceps delivery. Breastfeeding can be given unless there's a bleeding nipples, and defer treatment of mother till after delivery. There can be spontaneous clearance in these patients from 10 to 25% mothers, and we must wait for 9 to 12 months. And as far as the child goes, maternal antibodies may be present. So test after 18 months and treat after 3 years in the child. This paper came from Dr. Dhiman on the directly acting antiviral therapy is safe in children. And they treated children from age 12 to 18 years, and they had about 98% sustained viral response in a combination of soft DACLA plus ribavirin for 12 weeks in cirrhotics and without ribavirin in non-cirrhotics. And we see they had good response rates in patients who had with or without cirrhosis. In hepatology this year, this paper has come out on the role of SOF and riba in children who are 3 to 12 years, and the SVR rates were very good, 53 to 54. Only one patient stopped the medicine due to taste. Similarly, ledipasvir and sofosbuvir data has come with a response rate of 97%. Again, this paper has come in Jan 2020 in hepatology. So recommendations of children are wait for 3 years and early viral therapy if they have advanced fibrosis or extrahepatic manifestations. And the treatment therapy would be glecaprevir, pibrentasvir if they're more than 12 years. If they're less than 12 years, the treatment options would be between ledipasvir, SOF and ribavirin. And the doses can be are roughly based on the weight of the child. Acute HCV responds in 20 to 50%, and earlier we used to wait for 6 months, but the current recommendations are the responses are so good, the drugs are so safe that it should be initiated early without waiting for spontaneous resolution. And the short duration of therapy of only 6 months has been published this year in Hepatology 2020 of 6 weeks of glecaprevir, pibrentasvir with good response rates. Resource constraints scenario in India, the most treatment is not borne by state or by insurance companies, and we must be careful on what advice we are giving. We have to do the least and the cheaper investigations. We don't really need a viral load. Genotype and fibrosis assessment may be optional. Even the cost of a fibroscan should be considered. If there is no clinical or ultrasound evidence of cirrhosis, do APRI or FIB4. The drugs are good. So genotypes are not required. Core antigen is cheaper, but not yet been validated on a large scale. Generic drugs have been shown to be as well. And this drug, we worry about cost of therapy. But more than the cost of therapy, we must remember that if we treat them, this is the paper, we can prevent many decompensated cirrhosis, HCC, and liver transplantation. And this was a cost-effective analysis done by Dr. Rakesh very elegantly. There are many things available for providing free or affordable access to HCV care in India. Punjab has been the leader with Mukhyamantri Punjab Hepatitis C Release Funds. And similarly, in Manipur, there is the CONE network, which is the Community Network for Empowerment, which is a community-led public-private partnership chosen by WHO as one of the most innovative models for hepatitis C delivery in 2016. The national program, there's funding from the Global Fund Against AIDS, TB, and Malaria. The MSF with the Medicine Sans Frontier, which has got 2 projects in Meerut, UP, and in Manipur. So to summarize, I will say the treatment options in India in people without cirrhosis are addition of SOF with belpatasvir, daclatasvir, or ledipasvir. We should consider adding ribavirin in patients with, especially who are genotype 3, and patients who cannot tolerate ribavirin should be given 24 weeks of therapy in compensated cirrhosis. The carry-home messages are in decompensation, in DA preemptive therapy if the MELD is less than 20, and consider adding ribavirin or 24 weeks of therapy without ribavirin. In liver transplantation, again, we add ribavirin if they are decompensated. Treatment failures, pegylated interferon, standard therapy. In cirrhotics, add ribavirin. Soft failures, again, ribavirin. NS5A inhibitors, choose the preferred regimen would be soft velpatasvir ribavirin for 24 weeks. In HIV infection, the standard therapy is followed, but it's important to recognize drug interactions, and we have to take care with use of tenofovir. A hepatitis B co-infection reactivation is a worry. And if the patient is cirrhotic, you start nucleoside analogs before or with DA therapy. In kidney disease, the fears of SOF are no longer proven true, and it can be used. In pregnancy, we should wait for 9 to 12 months before treating the mother and test the baby after 18 months. In children, we treat after 3 years. Until 12 years, the choice of therapy would be soft ribavirin or soft ledipasvir. In acute HCV, we treat and don't wait for spontaneous resolution. In resource constraints, a pangenotypic regimen are there now, and we must rationalize our investigations. And I'm going to sort of leave you with this last blog on HCV, where since COVID is in the scene very heavily, where people have considered using SOF and DACLA for the treatment of COVID as well. And this is our team led by Dr. Acharya, who's a leading teacher to us in Fortis Escorts. Thank you.
Pankaj, it has been wonderful, very crisp, very clear. Maybe it has almost more than 100 questions, but I thought there is a couple of interesting.
Setu, we have some questions.
2 questions.
Yes. Answered first. Okay. You could start questions, or
But Pankaj, you want to show these questions to you prepare 2 questions for audience poll. We can start with that.
Yes. Should I be sharing them, or somebody will share them?
You share them. You share for your presentation.
So give me a minute. Where is sharing on? Okay, screen.
Yes. Maybe the 3rd question.
Okay. So this. So what is your preferred treat? So I think this is not really a quiz in sense. It's more to understand what the people's choices are currently. So what is your preferred treatment for hepatitis C genotype 3 compensated cirrhosis? Would you use SOF and Velpa or SOF and DACLA for 12 weeks? Would you add ribavirin and give this for 12 weeks? Or would you add ribavirin. Sorry if the last option is ribavirin for 12 weeks, 24 weeks, sorry.
So you can put your responses, and those on Facebook can they put the responses on the Facebook itself, and Yogita will let us know the responses. Yogita, please let us know as you are getting ready to get responses.
Pankaj, while we are getting that, there was a question from Anil Arora about timing of anti-HCV therapy in patients with HCC. It looks very difficult question actually.
The timing depends on the treatment options for this patient. If the patient is going in for a transplant and is waiting, if the patient is going in for a transplant, do the transplant. It should not delay the transplant. On the other hand, if there is a waiting, patient is on a DDLT list, or patient is undergoing downstaging procedure and can tolerate the drug, then treat the drug. The treatment for HCC should not delay the therapy. That's the point which is important.
I remember there was a paper in NEJM talking about cardiac transplant, that you can start the anti-HCV regime even on day 1 or day 2 of the post-op, which didn't make any difference in treating. So there is one lesson, which is there is no hurry to treat these transplant patients while the transplant is the priority.
True. So that's why I said the right time is roughly 3 months, by which time you've stopped the antibiotics, you've controlled infection, you've got rid of you stable immunosuppression, kidney functions are normal. You don't want to start a therapy and then have them break down in the therapy.
So
Somebody questioned is there anything like...
we have answer now available that Pankaj can talk about these. That you can see the... This is the answer 3, the soft Velpa and ribavirin for 12 weeks. 50% people said, 25% said soft and Velpa.
50 said, sorry, I couldn't hear that.
Soft Velpa and ribavirin for 12 weeks.
For 12 weeks.
And the second 25% said soft and Velpa for 12 weeks.
So I would still say that there is an importance of adding ribavirin in patients, as I showed you in data. Even in compensated cirrhosis, there is data on use of ribavirin. The ASLD guidelines are recommending that we check Y93 mutations before treating these patients. And if the mutation is present, then you add ribavirin or you use an alternative regimen. But since we are not checking for the mutations, it makes sense to add ribavirin and treat them for 12 weeks.
Perfect. So we can go back to our, you can stop sharing your screen and we can go back to the questions. You wanted to ask this question also? Okay. All right.
This is the last, the other question. Well, this is a standard thing which I thought I'll understand what people do very routinely. So how do you follow up a patient who has achieved an SVR and repeat a HCV RNA every 6 months, repeat a HCV RNA at 1 year, or repeat a HCV RNA once more after 6 months? Don't repeat the HCV RNA, only screen for HCC and varices.
So your responses, please, on this question.
While the response is coming, do you have anything like HCV RNA levels, like we talk about HBV DNA levels, 2000, 20,000 or something? Do you have any level by which we say treat or don't treat?
So, well, you're right. You know, we used to worry about these levels, and these levels, which we can see in this current slide, we used to have cutoff levels of 4,000 or 6,000 international units, and these are really very important in the interferon era. Currently, they are not important. The levels are lower or higher, you will still continue to treat them. The newer DA have done away with the value of these RNA levels.
They talk about this IL-28 mutation. Is it all important now?
The IL-28B also is no longer as important in the presence of DA. See, the results are outstanding with the new EA. So why are we bothering to increase therapy? They're even saying don't even do genotype.
That's right.
Why
That's
we are
right.
not even doing genotype? Why would we do IL-28?
Look, Pankaj, can you show the questions again so that we get the responses?
Okay, sorry.
Yogita, if you can share your screen and show the responses.
So you can read the answer actually. Okay.
Yes. So again, this is here. 45% would say that no repeating of CVRNA and only screen for SCC and varices. 23% says repeat SCVRNA once more after 6 months, and 18% repeat SCVRNA every 6 months.
So practically what we see is the right answer would be that there's no need to repeat RCVRNA and only screen for HCC and varices. But practically what we see is almost everybody across the board will repeat the RNA once more. Maybe it's partly to recheck that the result was appropriate more than anything else. But very often what physicians would be doing would be do HCV RNA every 6 months, and that part is not acceptable.
Maybe stop your sharing your screen now and we go to questions by
Dr. Pankaj, over 150 questions have come in, and in the next 8 or 10 minutes, I'll try and take you through and for quick, crisp answers to as many questions as we can cover,
Sure.
and then maybe Dr. Setu can step in after that.
Sure.
So, Dr. Anand from Chennai, in a talks of a
Always ask the most difficult questions.
yes, is hepatitis C treatment in a patient with cancer. So chemotherapy. Is there concern about HCV reactivation on chemotherapy? And as you do for HBV, is there any suggestion that some preemptive treatment for Hep C should be given in a patient who's undergoing chemotherapy for cancer?
No, sir, currently no such recommendation.
So
no such recommendation. But also, if they are RNA positive, we need to consider waiting and seeing their response rate and likely survival before we give them, if they are RNA positive.
Yeah, if they are RNA positive, you would like to treat the cancer and treat the Hep C later.
Unless if we find that the likely survival is less than 1 year, then probably not even treat them at all for hepatitis C.
Okay. Okay. Another question is, I think there are a lot of questions about the HBV, HCV co-infection situation that you did touch upon. Dr. G.K. Pati from Cuttack wants to know, when both are present, how would you decide which is the dominant virus, B or C?
So that part of therapy depends. You have to look at I will talk of the hepatitis B part. In B, there are going to be a couple of situations. First is that the HBsAg is negative. Only the core antibody is positive. Even these can reactivate. The second part is if they have HBsAg positive, the DNA is low or negligible, they can reactivate. The third situation is if their HBsAg is positive and the DNA is high. And the last is HBsAg is positive, DNA is high, and they have fibrosis and raised AST/ALT. They are in any case an indication for treating hepatitis B on their own. In such a situation, you will treat in any case. If they are cirrhotic, you will treat in any case. If they have only a raised DNA, if they have only a positive HBsAg without raised DNA, you wait in these patients.
Right. So
maybe I will go back and share that slide once again, which was nicely. See, the EASL guidelines are recommending that you treat everybody. That is difficult to accept right now because so let me go back and
going back. A related question is, if you have actually put a patient on antivirals when assuming dominant HCV infection, what are the tests you would do to monitor for hepatitis B reactivation?
See, in patients who are going to treat for hepatitis B, If their DNA is raised, the enzymes are raised, you treat them like routine chronic hepatitis B needing treatment. The
No, I'm not
situation
saying that
happens.
whole monitoring for reactivation. The
Is it
person,
ALT is enough or you need DNA
yes, you
more
are
often?
with the antivirals for C, and then how would you check for B reactivation?
See, if B reactivation is a combination of enzymes and DNA, how closely you monitor depends on what is the underlying liver. Is it cirrhotic? If it is not cirrhotic, if the patient has no underlying cirrhosis, then AST ALT is enough. If you want to do, the recommendations from the ASLD guidelines are that you monitor both DNA and ALT every 4 to 8 weeks and for 3 months post treatment. That's a lot of monitoring. You can justify that monitoring in people who are cirrhotic. Practically, it's easier to do ALT and do monitoring only once at about 8 to 12 weeks, at about 8 weeks of therapy. The recommendations are almost do monthly. You're going 12 weeks of therapy. The ASLD recommends you do DNA every month. EASL recommends treat everybody. I would say that our choice of monitoring should be dependent on the underlying fibrosis and cirrhosis. Anybody who has cirrhosis or advanced fibrosis would require close monitoring because reactivation can worsen and tilt the balance.
Yeah.
If the patient
make it.
has, last one statement on this, if the patient is only HbA1c positive, DNA is not there, and the patient has advanced fibrosis, I would do every month DNA. But if the patient does not have any significant fibrosis, the fibroscan is normal, no fibrosis, then every month is a bit much. I think we have to look at the cost of therapy or investigations.
Can I make a comment? There is an important rider is once you start an anti-HBV therapy, it would become lifelong.
The EASL recommendations are saying that you can stop them 3 months after stopping DA therapy.
Which may not actually happen.
Which may not actually happen.
I think, yeah, okay. So I think there's a whole lot of questions, and if we need to be a bit quick in our responses and crisp, I think it will help in covering more.
Okay.
Right. So I think you mentioned that DACLA, although soft DACLA are considered a pan-genotypic combination, many of the European and American guidelines are not mentioning it. So this is a question that Dr. Jayanti from Chennai, Dr. Piyush Thakur from Varanasi, and Dr. Shrikant from Delhi are also asking that if it is pan-genotypic, why does it not find a place in the other guidelines?
I would love to know everybody. I would love to ask everybody what's the dynamics behind it all. For a drug which shows that without cirrhosis, you're having as good, if not better result than soft Valpartosware, how you written a drug off, which is cheaper. And you look at the cost of therapy is about 1/3. What is procured in the national procurement, the cost is only 1/3. And I see no reason and see no logic. Yes, people who have decompensated cirrhosis don't do well. But what about compensated people?
Right. So I think probably it's very difficult to explain why exactly it hasn't happened. But at least our experience in this part of the world is that it works quite well. And for our Indian patients, we are quite comfortable using this.
The US veterans data of more than 5,000 people has also shown that the results of DACLA are very good. So their registry of the Veterans Association, US Veterans Registry showed a very good result.
Right. So Dr. Vivek Bhatia from Delhi wants to know something about that. You covered it only briefly about management of needle stick injuries from a person who is HCV positive. How do you monitor it? How frequently do you test the healthcare worker who might have been so exposed?
See, the earliest RNA would be coming at about 6 weeks or so. So about 6 to 8 weeks, you can check the HCV RNA. The antibodies would come after 3 months. And that would be the appropriate way to look at these people.
Can I ask, you didn't make mention about the difference between thalassemic children versus non-thalassemic children, because that was one question that has been there. Do they make a difference in the current
Fibrosis,
regimes?
just the presence of more fibrosis. And in children, the regimen which is recommended would be
Age-wise.
soft Velpa or soft Ledipasvir.
Well-power soft lady pie. Yeah, that was what Dr. Patwari from Ahmedabad wanted to know.
Yes.
How are you going to treat children? Because one is that they are thalassemics with maybe liver fibrosis, and the younger age group. So you mentioned that soft
Soft and Riba or soft and Ledipasvir. These two have been tried. Data of the others is still awaited.
Right.
I thought of asking, there was a debate a couple of years back that anti-HCV therapy prevents HCC. There was a big debate even in NEJM also.
So there has been in fact, there was a reverse thing as well, whether there was higher evidence of HCC in people who have DAs as compared to interferon. But this year in January, we've had a paper in hepatology which has negated this, that there is a treatment of HCV with DA was not associated with increased waitlist tumor progression or HCC recurrence after liver transplantation.
So
that's published in liver transplantation in 2020. Sorry.
The fear about the increased HCC risk is largely unfounded.
Unfounded.
And people, you would go ahead with treatment with DAs and not worry about the HCC risk too much.
Yes.
Similarly, in HCC, question was asked earlier also. This is slightly, Dr. Akash Roy from Chandigarh is asking, HCV treatment in a patient with HCC, liver cancer. Immune checkpoint inhibitors are causing a rapid regression in the size of tumors in many situations. So does that affect your timing of initiation of antiviral therapy for HCV?
See, I think the choice of therapy depends on what you think is the drug interactions, the survival of the patient. And most of the survival when we talk of is non-liver survival. Because if this patient gets downgraded, goes in for a downstage, goes in for a transplant, things change. So when we talk of survival of a patient in cancers, that is non-liver cancer. So here we would, if the patient is stable and we think the patient is doing reasonably well, we should consider treating. Also remember, drug interactions and risk of decompensation needs to be kept in mind.
Right.
So I think one syndrome, I'm sorry, Saraswat, one syndrome which need to be mentioned is fibrosing cholestatic hepatitis in a post-transplant situation, which could be HCV related. Could you comment on that?
That's one place which has always been a big fear. And although it's rare, it does exist. And there is now data to show that there is benefit of DA in these patients as well.
So I think we spoke about the Y93H mutation in genotype 3. Dr. Ankush from Jammu wants to know that if there is a decompensated cirrhotic with genotype 3 and has the Y93H mutation, what would be the treatment option?
Right now, our only Ramban is soft Velpatasvir with Ribavirin.
Did you get that? Sorry, I missed.
So right now, our best treatment option is soft Velpatasvir with Ribavirin for 24 weeks. We start with Ribavirin at low dose and step it up.
And Dr. Shreya from Lucknow is asking about a compensated liver cirrhosis genotype 3 in a patient who is not tolerating ribavirin. So in that, normally give it for 12 weeks. So is that an indication for increasing the duration to 24 weeks?
So whenever you want to give ribavirin, they don't tolerate, you double the treatment duration to 24 weeks.
Right. Any information on occult hepatitis C infection, its diagnosis and treatment? Is Dr. Josefa from Mumbai wants to know about occult hepatitis C infection.
Occult hepatitis C, the antibodies is negative, the RNA is positive. This is often seen in people who are immunosuppressed, people who have HIV, people who have chronic kidney disease. And if we suspect in these patients, we would check the HCV RNA. If you have LFT derangement in these patients, we would check HCV RNA to diagnose them.
This often happens in dialysis patients, I guess.
So chronic kidney disease, HIV, common.
So you treat them according based on their RNA levels. Dr. Shivanshu from Delhi, again, you mentioned about MELD purgatory. So finally, which patient with MELD more than 20 who is waiting for a transplant should be treated with antivirals?
See, if patient is going in for a transplant, which is realistically possible, we should wait. If the patient does not have a transplant option, patient is on for example, a DA list where you're not going to, we don't think you're going to get a liver in next 3 to 6 months. You want to treat these patients? Yes. Beyond 25, never. Beyond 20, with lots of caution. And that's the way to look at it.
Okay, right. So should you be adding ribavirin routinely to all compensated genotype 3 cirrhotics is what Dr. S.C. Das from Dhaka wants to know. And also
Yes,
Dr. Ajay Kumar from Rishikesh.
Yes, we should. And the logic which I have given is twofold. The first is that the data has shown that ribavirin results are slightly better, more so in some people who have mutations. The ASLD guidelines themselves have mentioned that before you start treatment in these patients, you check for mutations. You're not checking for mutations. Please add ribavirin.
Right. So finally, I think one last question is regarding the timing and indication of treatment in acute hepatitis C. How long would you wait for spontaneous clearance? When would you start antivirals? This is Dr. Chandrakant from Hyderabad wants to know.
Earlier we used to wait for 6 months. The current recommendations are no waiting. And the current, because the drugs are safe, the drugs are effective, and the even shorter durations of therapy of only 6 weeks therapy has come and been published this year in hepatology in 2020.
Right. Well, over 208 questions, 210 questions have come in. I don't think now you'll be able to handle all of those. If you have any pressing questions, Dr. Setu Babu, otherwise I think we'll ask Dr.
I think the HCV has taught us many things, and it was the first publication in NEJM about interferon in acute HCV. It was published even without a peer review, and they were claiming that this is the first publication. The nature of publication was like that. I think it was so demanding treatment, and now it has become so simple. The only question is, are we getting lesser and lesser patients of HCV, or are they being treated at primary level and they're not reaching tertiary level? They seem to be much less.
You are right. We are seeing less and less. There was an era when we would be treating them with interferon, and interferon therapy was messy therapy. They were sick, they needed erythropoietin, they needed close monitoring, they had side effects, and nobody wanted to treat them. Now, therapy has become so simple. Just give 1 tablet a day for 3 months. So many people are treating in the peripheries. But I think the important thing is to make sure we explain the follow through. We make sure we explain the importance of sustained virological response. More and more, as the newer DAs have come and become effective, we as gastroenterologists have still to come to terms with our own irrelevance. So therapy is being offered at smaller centers. That's great. People who need to come to larger centers are people who have co-infections, comorbidities. The peripheral centers which are treating, need to be sort of reinforce the need for appropriate therapy, appropriate follow-up, and ensuring SVR.
I think the nephrologists have become a great Hep C specialists, because they have been treating even without even referring.
True.
Saraswat.
Right. I think, Govind, are you there?
Yes. So I think we can stop here. We had a wonderful talk by Dr. Pankaj Puri on how do you treat a chronic hepatitis C, not only uncomplicated, but also in many complicated situations, which we often see in our clinical practice. I hope the guidelines Dr. Puri went through all the literature of EGL and ASLD, including Indian guidelines and the national guidelines. So thank you, Dr. Puri, so very much for guiding us an important part of therapy. Also, Dr. Setu Babu made a point that many patients are not coming to us, probably they're treated. And this is what we call that this is kind of strengthening our healthcare system, that you're able to treat such common diseases at at your primary or secondary healthcare system, and only those with advanced diseases they come to tertiary healthcare system. This is so wonderful for any country, that you are able to treat common diseases at their patients' home place. This is a So it was a lightning experience for us to learn and to listen to Dr. Pankaj Puri.
If I'm not tickling Pankaj, it was a fantastic review of a very, very well-known subject, but it was a fantastic review. Thank you, Pankaj.
Thank you so much. Thank you for your kind words. It's been a pleasure to be with you.
Thank you, Dr. Setu Babu, for again moderating and bringing some new thoughts about Hep C. So thank you so very much for joining for this masterclass.
Thank you.
So we formally end this masterclass today, and Dr. Puri, we have about 200 questions. Some we could discuss here, but some of them are really important. They're still pending to be discussed. And if we get time to respond to these questions, it will be wonderful. And as part of the uniqueness of this masterclasses, we try and respond to many questions as far as possible and put them on website along with the videos of recorded videos of these talks. So all those who ask questions can go back and look for those responses. And this is what becomes a good learning experience for everyone. Let me invite you for the next talk, which is going to be held on 12th of July. And this will be talk on very important topic, which is a gastroesophageal reflux disease. It's really common. About 15% of our population has GERD, but we will not talk much about a routine GERD. We will talk about situations where difficult to treat GERD situations, and how to address those situations where you have patients where GERD is hard to treat. And for that, we have again one more renowned speaker on that, Dr. Sobna Bhatia. And many of you might be aware that she has been leading the Indian Scientific Gastroenterology Task Force on GERD for last about 10 years, and published the paper on guidelines of GERD treatment in India. So we look forward to hear from her next week on 12th of July at same time 12 to 1, a talk on difficult to treat GERD by Dr. Sobna Bhatia. All these masterclasses have been archived on the ISG website and also on the YouTube page of Indian Scientific Gastroenterology. You might like to go there and revisit these wonderful talks delivered on very common clinically relevant topics. With this, we want to thank everyone, all the viewers from India and abroad. We want to thank the learned speakers of today and moderator of today.
Thank you.
We want to thank Dr. Saraswat, thank Yogita and Dinesh for again webcasting this masterclass. And we do want to thank Dr. Reddy's Lab who are supporting these masterclasses these few weeks. Thank you, everyone, and we look forward to see you next week on 12th of July, 12 to 1, for a talk on difficult to treat GERD by Dr. Sobna Bhatia.
Thank you.
Bye-bye.
Thank you.
Bye-bye.
Bye-bye.
Bye, sir. Thank you.